This is a gift that will help us meet the challenges over the next 25 years.
The Erin Mills Development Corporation has made an extraordinary gift of $6 million towards the new Regional Women's and Children's Health Center.
We're fortunate to be able to do this, and it goes to a very, very worthy cause. Thank you again.
Erin Mills Development Corporation is owned by a group of 5 families that started this community by building the homes, shopping center, and buildings that surround the hospital. Their generous gift now gives back to the community that it built by leaving a legacy that secures the health of future generations. Future generations start here, in the new birthing suites in the neonatal intensive care unit.
We are preparing now to move into the new birthing suites in May of 2011. We will be leaving a unit that was built for 2,700 births, having 8 birthing rooms, into a new unit that will accommodate the current births of 5,000. And we will have 15 birthing rooms as well as 3 operating rooms. We'll have a separate unit that is for assessing our outpatients, and that'll be called the labor assessment unit, where all our families will come and meet us first, and we'll determine whether they need to be admitted into this new birthing suite or not. So our new birthing rooms are equipped to completely manage a patient in active labor. If she were to have pain management, it would happen in that room. She would labor, deliver, and postpartum for a brief period. We also have a bereavement room for those families who have suffered a perinatal loss. We find in the new build that we're meeting new ministry standards with our hallways and our rooms, and that makes it much more bright, spacious, more comforting environment for our patients in labor. We will be bringing midwives on board in the fall of 2011, and they will completely care for their own patients in one of our birthing suites. So in the immediate postpartum period, once baby's born, we deliver the baby up to the mother's chest and encourage skin-to-skin care right after delivery. The baby should not be disturbed for the first half hour after birth, and shortly thereafter, if mom is breastfeeding, we would put the baby to breast or assist the baby in finding its way to breast, and we would make sure that that's all done before the mom and baby are transferred to the mother-baby unit. A small percentage of our babies would require high-risk care, so staff from the neonatal intensive care unit would be present during delivery and would help stabilize the baby and determine whether the baby required care in our neonatal intensive care unit.
During the design phase, there was a lot of input from nursing staff and pediatricians, and we were able to accommodate larger bed space so that we would be able to have the families at the bedside. The families will enter the unit by secure door access. They'll gain entry by communicating with the reception area. The amenities that we put in are 2 care by parent areas, a place for mothers to stay with their babies prior to discharge. That baby would be in the room with the mom or dad and or support person for the families to feel more comfortable away from the actual bed space that they may have been cared in for numbers of days or weeks. And the family can then prepare for the baby's discharge. So the family would do all the care on their own with a nurse close by within the unit. Want the families to be at the bedside and learning about the care of the baby and participating as much as they're able and advancing to total care prior to discharge.
Through all of this expansion and new facility, we will be living our promise to our community to meet their needs in healthcare.
Throughout the year, our staff receive training in the latest medical innovations and procedures. This ensures that we are able to provide high quality and safe care for our patients. Let's take a look at a recent Code Pink training session.
Today we were working together with the pediatric department and the emergency department to work through some training sessions on different scenarios of children that could present to our emergency department and get some hands-on practice providing the best possible care that we can to those children. It's very important for us to get together as a team to practice. Every other team practices. If you were playing soccer or any other event, you would be practicing as a team. And so in order for us to be able to provide optimal care in our emergency department, the team that would be providing that care needs to work together and practice together to be able to do that successfully. And so we feel that by doing these different sessions that we pick typical scenarios of patients that would be seen in our emergency department so that the team gets practice working through those different situations together.
Okay, so your patient is an 8-month-old boy who's had 2 days of fever, irritability, poor feeding, nasal congestion, and cough.
First thing I do is I look at the child, so just get the parents to first undress the child, and what are my first impressions when I first look at this child?
So the child appears pale, he's crying, he has slight tachypnea, breathing quickly with no retractions. The heart rate was over 200, it was too fast, they couldn't actually determine how fast it was. The blood pressure was unable to measure, although you could feel a good pulse.
I would check the fontanelle, look for signs of any dehydration in the mouth, signs of infection, dehydration. I would look for focus on infection. I mean, this child has a fever right now, so listen to the lungs, check the belly, look at the skin, turn the child over. Is there anything that I see?
He is pale, cool, and mottled with a refill of 3 seconds, a rapid heart rate but no murmurs. He's crying and moving all limbs, and he is slightly cool to touch.
So right now, as a group, we're thinking that this child probably has sepsis. We have the child on a heart monitor here. Let's get a 12 ECG if we can as well. Let's give this child some Tylenol.
I'm getting a Tylenol. Thank you.
All right, so this is a very fast rhythm. I don't see any P waves, so this could still be sinus tachycardia.
The child becomes less responsive, begins sweating, has a diminished pulse, and the heart rate goes up to 270.
Let's call it co-pink, get pediatrics down here, get anesthesia down here. This child needs to be intubated.
Given the fact that we're a regional pediatric center and we're becoming a teaching hospital, I think it's important for us to be as good as we can be. And ultimately, if we practice this, it'll be to the benefit of the kids that come in here. We'll give them the best care they can get. And there's good studies to show that people that, when you work in this kind of situation, if you work as a team, then the outcome is better. And so by practicing and by getting the roles straightened out and by bouncing ideas off each other, it actually works well, and it allows us to work as a unit much more cohesively.
Being able to go through a run like this is actually very important because in reality, we don't see codes like this very frequently, so you can get rusty very easily. Being able to practice under a pressure situation is very important, and it allows you to practice your communication with your team, so it's very good.
It was extremely successful. The feedback we've received from the staff that have gone through the session, they feel that having this practice and working together as a team will optimize the care that they're able to provide to our community and to the children who present in our emergency department.
Thanks for joining us. We hope you enjoyed the show. On behalf of everyone here at Credit Valley Hospital, we wish you good health. Remember, do your best and life will do the rest. For Credit Valley Contact, I'm Dan McGann.